Let's look at some examples of how evidence is reported in social media and how, without appropriate knowledge of the purpose, design, and reporting of results, you're manipulated into believing what the poster or blogger wants you to believe. So let's look first for headline, eye-catching phrases or stats. Here's a LinkedIn post asking if your child suffers from ear infections, and then posting what looks like significant results, 75% improved within 10 days or less. But let's look closer. Here's the study entitled Ear Infection, a retrospective study examining improvement from chiropractic care and analyzing for influencing factors. So we know several things. It was published in the Journal of Manipulative and Physiological Therapeutics in 1996. This is one study in a private practitioner's office. It's retrospective, but it's a case series and dependent on the reporting of symptoms by parents. There were 46 children, ages 5 years and younger. Results: 93% of all episodes improved, 75% in 10 days or fewer, and 43% with only 1 or 2 treatments. The researchers claim that there was, quote, very little data found regarding the natural course of ear infections, unquote. So, how can this be rephrased to represent more an evidence-based statement? This is a single retrospective case series study of children with symptoms of ear infection published in JMPT in the late 1990s, demonstrating improvement in 75% of children within 10 days when treated chiropractically. A reminder that retrospective studies by design cannot be used to demonstrate cause and effect, and certainly not a case series. The approach was proprietary, meaning it was specifically developed by the single practitioner in the study. Although the authors claim there was little evidence on the natural history of ear infection, a quick PubMed search revealed we actually do have the evidence about the usual limit of symptoms for children with ear infections. 61% of children with acute otitis media symptoms improved within 24 hours and 80% within 2 to 3 days, and so it doesn't appear that those that improved in the study beat that natural history. We don't even know if they had an ear infection, just the signs of ear infection. We do know that allergies, viral infections, and smoke can also cause similar symptoms. So what did you need to know? That case series are at the bottom of the evidence pile due to their lack of statistical requirements and high bias. What did we learn? Well, case series and case reports are simply observational without a comparison group. Without comparison to a group without chiropractic care or placebo or sham, it's not possible to determine a true difference, a statistical difference between those treated chiropractically and not. You can't use statistics due to lack of a comparison group. You are obliged to find higher level evidence when possible, and certainly systematic review if possible. And regarding a systematic review, there are several. The one below is consistent with all others, saying the evidence is inconclusive. And here's an intriguing headline from apparently Reuters. New study from the Chiropractic Doctors Association of Hong Kong finds chiropractic care reliefs tension, headache, and long-term depression. Yes, it says reliefs, your first clue. Further, quote, a new study by investigators in psychiatry and chiropractic at the New York Medical Group found that patient, yes, I said patient, suffering from tension, headache, and major depression has the long-term relief after chiropractic adjustment, unquote. Do you believe this is actually posted by Reuters Health? I guess they need a new copy editor. Well, first of all, we see this as a case report, meaning only one patient. Secondly, we learn nothing new in the abstract. Instead, some tangential, hypothetical rambling about why she might have improved. Again, not clear why a team of psychiatrists and chiropractors was needed for this one case. This is more than disappointing, and nothing like the implications from the post. Here's another from the same, quote, researcher, unquote. Bridging the gap between observation and brace treatment for adolescent idiopathic scoliosis. Again, a single case. The curves were 26 degrees in the thoracic and 23 degrees in the lumbar region. After 6 months, they noted an improvement of 6 degrees in the thoracic and 7 degrees in the lumbar region. But of course, they reported as a percentage of improvement. So this then augments the perceived degree of benefit to 23% and 30% improvement respectively. Problems? Well, number one, curves in this range sometimes spontaneously improve or don't progress. Also, the Cobb angle measurement has an error range of about 3 to 5 degrees, which would potentially contribute to the observed benefit. So although a potential good start to a larger study, this single case, with the potential contribution of some error in marking and interpretation, in no way proves or even substantially suggests that chiropractic is yet an option. Perhaps it could be called emerging evidence at best. So what did you need to know? Well, again, case reports are at the bottom of the hierarchy of evidence. What did we learn? Case reports are simply observational without a comparison. They can't use statistics due to lack of a comparison group. And from the scoliosis case report, compare outcome measures to determine the margin of error in measurement. And for adolescent idiopathic scoliosis, compare to natural history. And of course, search for higher levels of evidence, including systematic reviews. In fact, a recent systematic review of AIS failed to find any studies that currently demonstrate significant effects beyond natural history, as much as we would like to believe that manipulation is of benefit. Another post on LinkedIn suggesting that, quote, a chiropractic adjustment can give your system the opportunity to fight disease better. Did you know spinal adjustive care increases immunity and decreases risk for infections? Go to the chiropractor, unquote. Except this was published in the Journal of the Osteopathic Association, and it was not only not chiropractic, but also not an adjustment. It was, in fact, a lymphatic drainage approach. The small increases in certain plasma cytokines were measured immediately after with no long-term follow-up to determine the duration of effect. So, therefore, we have no idea of the significance or lack thereof of this single marker that is indirectly involved in immune reactions. What did we learn? Check your references. Let's move to actual studies. Here's a recent controversial study. The researchers hypothesized that a hypolordotic cervical curve may have an effect on vascular supply to the brain. So they used magnetic resonance angiography to measure blood flow to the brain in supine patients. Then they used a correction device to increase the cervical curve and performed the MRA with the patient's curves improved. They showed increased pixel intensity representing increased vascular flow to the brain. This sounds exciting, and may be, but to extrapolate these findings, as many did online, is not evidence-based. Here's an example. He states, quote, when they forced the neck into a proper curve, they found that it improved blood flow to the brain by 200%. This is very exciting because it shows definitively, and possibly for the first time, that improvement in curve of the neck improves blood flow. Interestingly, one of the main hypotheses associated with Alzheimer's and dementia is that it can be caused by a lack of blood flow into the brain, a condition called chronic cerebellar hypoxia, and there is also evidence that ADHD in children may be associated with poor blood flow to the brain, unquote. How about a more evidence-based summary? A single case series publication using MRA determined that after using a device to improve supine cervical curve measurements, MRA pixel intensity increased by 23% to 235.9%. Regression analysis indicated that 33.8% of the possible changes in observed pixel intensity can be attributed to the initial measured cervical lordosis. In other words, only a third of the effect of the change in pixel intensity was due to the change in cervical curve. The required sample size to produce a significant correlation between lordosis and change in MRA pixel intensity is an N of 16 to give an 80% chance of achieving a p-value less than 0.05. However, this study involved only 7 patients. What did we learn? Statistical significance does not necessarily mean clinical significance. Short-term response using an indirect measure does not convey any sense of clinical significance. For example, if correction occurs only supine, are the benefits only lying down? What happens with gravity added and associated muscular interactions, and that effect on blood flow? This blogger's connecting Alzheimer's and ADHD represent logistical stitching, connecting basic science ideas with clinical science, allowing extrapolation from one to all. So the results were statistically significant. What is statistical significance? Imagine you want to hire someone whose education is based on a pass-fail grading system. All you know is that they are minimally competent, but you can't distinguish them from someone who may have scored significantly higher on testing. In other words, the quality of their education and knowledge. The same is true of literature evidence. Statistical significance simply means minimally competent from the perspective of science. What we must know clinically is the effect size or difference of effect, one that patients would perceive as meaningful. For example, although a study may be clinically significant in the difference between two groups, if the study was pain and the difference between groups was 1 on a 10-point scale, is that something patients would feel differently or value that difference compared to the other group? So what happens when studies don't prove that what I do in my practice works? Well, first of all, what's the purpose and design of research? In an effort to minimize bias and chance, researchers study a well-defined population using inclusion and exclusion criteria. They compare at least two groups, see if there's a significant difference between or among groups, which is statistical significance determined by p-value, confidence interval, and power, and then determine if that difference is small, medium, or large to determine clinical significance. This is determined by differences in effect sizes. So the question is, can you do the same with your practice observations? That's a rhetorical question. Let's look at an example of what many would claim is not representative of their experience in practice, especially sports practices. 4 studies showed SMT had no effect on physiological parameters at rest or during exercise. There was no effect of SMT on scapular kinematics or transverse abdominis thickness. 3 studies identified changes in muscle activation of the upper or lower limbs compared to 2 that did not. 5 studies showed changes in range of motion, 1 study showed an increase in lumbar proprioception, and 2 identified changes in baropodometric variables after SMT. Sport-specific studies showed no effect of SMT except for a small increase in basketball free throw accuracy. The summary? The preponderance of evidence suggests that SMT, in comparison to sham or other interventions, does not enhance performance-based outcomes in asymptomatic adult populations. A pretty specific statement. So what do we need to know? That systematic reviews are at the top of the hierarchy of evidence. Systematic reviews do not study patients, they study studies. Regardless of how many high-quality studies, the researchers of a systematic review must rate them and report on what they find. Screening for bias, heterogeneity, and power eliminates less valid studies. So don't shoot the messenger. The analogy could be, what if you were assigned to judge a gymnastics event without knowing the rules of the sport, the scoring rules, and the statistics involved? Well, you enjoy gymnastics, so you can have an opinion about whether you liked what you saw. An opinion is your right. But you don't have the knowledge or skill to critique the performance, nor the judges. And what if you scored the performance a 9 out of 10, yet the mean score for judges was a 5? Can you simply ignore their determination? They're the trained experts, and you're not. Yet many chiropractors discard or even use ad hominem attacks on researchers who conduct systematic reviews and conclude that there is insufficient evidence for manipulation for a given condition. So what are the researchers actually saying? Not a comment on the effectiveness of manipulation, but the lack of evidence. When reviewing the results of studies, you have to check your ego at the door. It isn't about you or your profession, your team. It's about a narrowly defined subset of patients and treatment approaches focused on by that research study in an effort to minimize the bias likely seen inadvertently by individual docs. And a final excuse used by many, often quoted, is that 90% of all research is flawed or false. This essay is likely the source of most of those concerns. This researcher is correct in many of his observations, but these are more intended to warn consumers of research to be cautious, to be an evidence-based reader. His concerns are focused on power and bias, the number of studies, the ratio of true to no relationships, and small effect sizes. He's also concerned about financial and other interests. What solves these concerns? Systematic reviews. They don't study patients, they study studies, and, if they're meta-analysis, they study RCTs. The purpose of systematic reviews is to determine not only the number of qualified studies, but rate them for quality based on risk of bias, heterogeneity, statistical significance and power, clinical significance through effect size, and, if statistically similar, portrayed as a forest plot. Here's an example where all the studies in a meta-analysis are graphically presented with weighting for size and often quality of each study. The effect box reflects the size and/or quality of the study, and the line represents the confidence interval and its relationship to the center line of no difference between groups. And the bottom diamond represents the mean of all studies taken together. So clearly, to be fully evidence-based, a working knowledge of what research is and how it's reported is requisite. Where do you get this information? There are many sources. A great website is the Centers for Evidence-Based Medicine. Also, in Michael Hainline's text, The Evidence-Based Chiropractic Practice is a great professional-specific source. The appendix at the end of my text's 5th edition, Differential Diagnosis and Management for the Chiropractor, gives a 25-page summary of the language and process used in incorporating literature into practice. A quick video tutorial can be found at Coffee Break U, the Evidence-Informed Chiropractor. Click on the EB Tools link on the upper left banner. This takes you to 4 free video tutorials that in total will take less than 2 hours to review, and of course, you can go back and refresh your knowledge. Other sources include podcasts. There are quite a lot. Here I'll mention a few, including Chiropractic Science with Dean Smith, iChirocast with Stephen Pearl and David Newell, and the Forward Thinking Chiropractic Alliance with Bobby Mabey, and the Evidence-Based Chiropractor with Jeffrey Langmaid. Each interviews leading researchers in an effort to provide listeners with a unique perspective from basically the horse's mouth about a particular study or a group of studies, what they were designed to do, and what the results actually indicate. So dig in and complete this triad.